Okay, the waiting room is clear. I'd just like to remind members, in order to vote and comply with open meeting law, you do have to have your camera on while voting. And with that, Gary, I'll turn it over to you. Can everyone hear me okay?
Yes.
Gary, I think the waiting room is clear, so I'm going to turn it over to you.
Okay. This is Barry. I'm sitting in for our chair, Patrick Merritt, and I'd like to welcome everybody. And I'd like to establish a quorum. Could you call the roll for us if you don't mind?
Yes, I'm happy to. I'm just now admitting Stephen Hoagland, so let me give him just a second. I'll start with you. Of course, we have Barry Martin,
Okay, here.
Dennis Fouch,
Here.
Michael Hill,
Here.
Patrick Merritt, Stephanie Moore,
Here.
and Stephen Hoagland.
Present.
Okay, thank you all. You do have a quorum.
Okay, great. Thank you. Let's start with any old business. Update on PHE and wind down process, redeterminations. Anybody?
This is Angie Parker. I'm not sure if anyone's on that can address that, but because I'm sorry.
I'm sorry, I said I don't believe anyone is on to address unwinding.
Our senior deputy
Okay.
commissioner is out on vacation.
Yeah.
Is there any
Understood.
particular questions that you have? It's ongoing, I can tell you that.
Yeah, we definitely know that.
Okay.
Does anybody on the TAC have any questions regarding it? Okay, we'll just put that on the back burner until the deputy commissioner comes back. Establishment of core quality indicators, uniform between all MCOs. Angie, you've been working on that?
I have been working on that, and I know that this has been something that you all have been waiting for. So I am going to bring this up. So I'm not sure, I am Angie Parker. I'm the Director of Quality and Population Health within the Department for Medicaid Services. So we're going to discuss the core quality indicators that the Department for Medicaid Services has come up with as in working with our managed care organizations. So a little background. Well, I started this with the background on the development of the value-based payment model, but actually this kind of started back in July of last year when the Department for Medicaid Services had a reorganization in which it developed a new division that included quality, population health, equity and determinants of health, and research and analytics branches. So that gave us an opportunity to really focus on developing a value-based payment program to incentivize our managed care organization towards quality goals and improving the healthcare outcomes of our population. So the expectation, and we were also, some of you may have participated in the development of the Medicaid managed care quality strategy, which was submitted to CMS last November. We did enlist some of the TAC members to provide insight into what we should be focusing on as a state for the quality strategy. So I believe it was last fall, we started working with Milliman, our actuary, on developing this value-based payment model. We did select performance measures and related targets, and we are to be starting this actual program in contract year 2024. So we've been doing a lot of work. We've been doing the design, and we've had conversations with the MCOs on this as well, and we are ready to kick it off. So what does that program design look like for the MCOs? We are withholding 2% of their capitation. There are going to be 6 core measures plus a bonus pool for those eligible MCOs. They have to achieve a 3% or 4% point improvement to earn any of the 2% withhold back. And they must earn withhold on 4 core measures and maintain performance on all core measures to be eligible for the bonus pool. So when developing this, and what was our strategy and goals? We want to reward plans that perform well and penalize plans that perform poorly. You know, we've heard this all the time, that Kentucky is always in the bottom of national state health ratings. So we're hoping that this will also help move us out of that 48th to 50th. Now, I did hear that we are now around the 45th or 47th. So there has been some movement as a state. We want to include performance targets that are realistic and achievable. And obviously we want to incentivize quality outcomes. That's the ultimate goal here. We want to consider regional or population-based goals to the improved disparities, be operationally straightforward to oversee or manage, ease administrative burdens for providers to participate, and there will be no need for additional funds to operate this program. Continued design, there's a pass-fail. I think I've mixed up slides here, but there is a pass-fail for the MCOs. They either pass it or they fail. So they will not get a withhold for missing 3% or 4% of the minimum improvement. Future year minimums will be set using our external quality review organization, which at this point it is IPRO, Island Peer Review Organization. We are utilizing HEDIS measures from EQR reporting. We're starting with HEDIS measures, and the baseline measurement year will be 2022. And the first measurement year will be 2024. And the first earnings, hopefully there will be earnings. We want all of our MCOs to meet these minimum improvements, will be the fourth quarter of 2025. So what this baseline measurement year means, right now, in 2023, there were HEDIS activities done in the first part of 2023 for measurement year 2022. So that is going to be our baseline year in determining the minimum improvements. So because we have that baseline right now in 2023, the measurement year for 2023 will be next year in 2024. It gets very confusing, but the idea is for all these measurement years, hit the baseline. Next year, they'll be really working towards improving those 2022 baseline, and then we can hopefully give them back 2% and bonus money if they are able to achieve those goals. So down to the nitty gritty, what are the core measures? So it's the hemoglobin A1C less than 8, postpartum care, which more specifically the percentage of deliveries that had a postpartum care visit within 7 to 84 days after delivery, child and adolescent well care visits, child immunization status, the CIS combo 10, the immunization for adolescents, the IMA combo 2, and social needs screening and intervention, which this is a brand new measure for HEDIS for 2023. So this is just going to be, this will be the baseline year for that specific measure. As you can see with these top 6 measures, we are targeting the chronic condition of diabetes, maternal health and children's health, and then the equity associated with all of the care that is given. So what will be the bonus pool measure? So if they're able to successfully improve on those measures, they are eligible for metabolic monitoring. They have to also meet a number of these bonus pool measures, which include metabolic monitoring for children and adolescents and antipsychotics, follow-up after emergency department visit for alcohol and other drug dependence, follow-up within 7 days of an ED visit, weight assessment and counseling for nutrition and physical activity for children and adolescents, counseling for nutrition. And those 3 things that, have to be documented: body mass index, counseling for nutrition, and counseling for physical activity. And then breast cancer screening. So all the previous page and the bonus pool measures are what we are targeting, our focus. That does not mean that all HEDIS measures are not important, because they are. It's very challenging to whittle down what our focus needs to be. We are focused on the overall health of our population, obviously, but this is where we are starting now, primarily, as I mentioned, some preventive care for preventive services for our maternal health and children for the most part. So the quick and dirty, are there any questions that I may be able to assist you with?
I think the reason we asked for this is to try to get all the MCOs kind of on board and get us focused as providers on more focused areas, because the MCOs at times throws so many different ones out along with Medicaid. It's hard to catch 50 or 60 of them. It's easier to catch 10 to 12 and keep those kind of across the board. So it looks good and consistent with what the major points of emphasis are.
Now, like I said earlier, this doesn't mean that other HEDIS measures aren't important, and the MCOs may, target certain areas if they are showing that their results, their particular results, are not improving. So there could be some of that, but this is, as far as a state, we are, those are the specific 10 measures that we do have a focus on. But we, like I said, we also want to make sure that we are improving in all areas for preventive services, for chronic diseases, social determinants of health, and how all that ties into all of the care that we are providing to our citizens.
Okay, we appreciate it. Any questions for Angie?
Barry, I have one.
Yes.
I'm curious if there's been conversation within DMS about how these measures might be distributed to other divisions and departments. For instance, when we talk about combo 10, is that really being pressed with WIC and other settings of care where those kids that are less than 2, or when we talk about, combo 10 with the little people and combo 10 with the adolescents, are we talking with like KHSA about emphasizing vaccines in that sports physical process? Because I think that one of the things that from a provider standpoint helps movement is for people to get messages across a lot of different settings of care, not just from their managed care organization or their provider.
That's a very good point. I can't say that that's been specifically addressed with other departments, but certainly like that point, and we can certainly look at that. And and I'll think about those as also with the Department for Public Health. We do work with them on a lot of different things. So this thank you for that recommendation.
And before I forget it, we need to roll back and approve the minutes from our last meeting. I apologize.
We need a motion for approval, Barry.
Yeah, need a motion for approval.
I'll make that motion.
Okay, do I have a second?
Yeah, I'll second.
Okay, all in favor, say aye.
Aye.
Opposed likewise? Okay, so move. Thank you. Thank you, Angie, for the update on the core indicators.
No problem.
Update on community health worker reimbursement.
I don't know if Justin Derringer's on, but there was a communication, I believe, the end of June out to the providers regarding this. And if you give me a minute, I also have a PowerPoint that I could share. I've got to find it. Unless Justin's on here.
Hi, Angie. Yes, this is Justin Derringer. And I'm the acting director for the Division of Healthcare Policy. So the community health worker program or project is completed, and that communication was sent out to all provider types. You should have received that sometime toward the end of June. That same communication, as well as a PowerPoint presentation and pretty extensive FAQs, has been put on our department webpage. We've put that on the front page of the Kentucky Department for Medicaid Services webpage, so it's easily accessible to everyone. And so it's complete and rolling, and billing has started. So does anybody have any specific questions on it, or?
Hey, Justin, do you happen to know when the updated rates will be added to the fee schedule?
Yeah, so the fee schedules have been yep, those rates, that's correct. The fee schedules have been updated. It just haven't been posted yet. So it takes some time. I don't have an exact date. I wish I could tell you an exact date. I'm hoping within the next, if not this week, then next week, those should be online. Because those were originally, I think some of those rates were different. We increased those rates, but within the next week or two, those should be on all the fee schedules. If they're not currently, I haven't
you.
checked. I know they were scheduled to be on there. When they get put on there is not really a, it just depends on what other things are in front of them.
Sure. Thanks for that.
Thanks, Justin. Anything else about community health worker reimbursement?
Only other question that I had on that topic was around the dental procedure codes. I noticed that there's an intent to add the CPT codes to the dental fee schedule. Is there an intent to assign CDT codes, so the actual dental tech codes, or is there an intent to do that?
So originally when maybe we're currently looking at different issues. We thought our system could be able to do that, to be able to bill that with dental providers sending those CPT codes in on their current forms. But once we started receiving those, we had some hiccups and some issues. And so we're in the process of trying to figure out exactly what we're going to do with those issues, but we're working on it. So I don't know exactly what the outcome's going to be.
Okay. From an MCO perspective, I just wanted to share, I believe that most of the dental administrators, I don't believe that their systems are capable of intaking a CPT code. And so if a dental provider who is contracted and on the platform from the dental administrator submits one of these codes, it's not going to be accepted. So just want to make sure that you understand that perspective.
Yeah, we've had to receive, we've been receiving some paper claims, and then we're working on the possibility of adding some different things. So we should have some guidance out again within the next few weeks on a fix for that once systems confirm.
Thank you.
Thanks, Justin. Anything else? Okay, let's go on to new business. With Veronica not being here, do we have any new business? Anyone from TAC have any new business? Okay, I guess if we don't have any new business, we can go on to reports from the MCOs. Aetna. Can you guys hear me?
Yes,
Yeah.
we can.
Okay. Anybody here from Aetna?
Hey, this is Crystal with Aetna Better Health. Can you hear me?
Okay, I can now.
Oh, I'm sorry about that. I think I had myself double muted. I just have a couple of updates today. We wanted to let everyone know that there has been some recent organizational changes within our PR department. So several of our network managers were actually transferred to different regions in an effort to improve the service that we provide to our partners. As a result of that change, several providers may now have a different network manager to work with going forward. We actually sent that out as a notification on, I believe that was 6/27. However, the updated listing can actually be found at our website. Excuse me. We do want to encourage everyone to go out to visit that website just to check on that listing. I'm sorry, I need to get a drink. I'm getting a little choked here. Sorry, just a moment. All right, I'm sorry about that. We also have a network notice that was sent out today surrounding prior authorization. And so we do want to remind all providers that if a medical necessary service has been performed and a PA was not obtained, you actually do have 7 days from the date that service was performed to submit a retro authorization request. That notice was sent out today, but if anyone is not on our network notice listing, I will put my email in the chat and we get you signed up for that. And I'm also going to put the link for the new network manager notification file in the chat. And that's all I have for today.
Okay, we appreciate it. Any questions? Okay, we have somebody from Anthem.
Hey Barry, Brian Richardson with Anthem.
Right.
Just had 4 different links that I wanted to share with the group today, and I'm going to put those in the chat after this as well. And the first one is Mental Health Forum. It is for youth mental health, and it's actually going to be a forum that's on September 27th. So please share that with anybody. I think that would be a good one to attend. The second one that we have is Advancing Health Equality, Meaningful Patient-Provider Relationships. So it's a good little link on that, talking about the different techniques between a good provider relationship. The third one we have is Help Your Patients Stay Covered. And that's a Medicaid renewal, which is going on right now. So there's a good video to watch with that one. And the last one that we have is the HPV vaccine. And that's a provider incentive for children ages 9 to 13. So again, I'll share all 4 of those in the chat so that they can be shared with whoever you want. Thanks very much.
Hey, Dr. Martin, this is Leon Lamoureux, the plan president for Anthem. Could I just maybe pile on to what Brian just said?
Yes, definitely. And I'm not a doctor, so
Okay.
Barry.
Well,
Thanks.
just, you know, the discussion that Angie led so artfully about the value-based payment arrangement, we've been going through our value-based payment arrangements for the provider communities and the PQIP program to align our provider incentives to fit neatly with those 10 measures that Angie was talking about. It's not exclusively along those 10, but at least from the Anthem perspective, you're going to see for 2024 a very close alignment between those things that we're going to be emphasizing and rewarding within the value-based payment arrangements and the pay for quality programs. So I just wanted to take this opportunity to let you know, we have heard, and I believe many of my colleagues in the other MCOs are planning to do the same thing, following the lead of what Angie has introduced with what they're terming to us, the, not to be confused with other vocabulary, the value-based payment for MCOs that involves that quality withhold and so forth. So look for new language and new contracts and so forth with the primary care community and all of the value-based payment arrangements for Anthem.
Okay, thank you. Appreciate it. Any other questions for Anthem? We'll go on to Humana.
Hey, this is Sarah Moyer with Humana. I'm the Chief Medical Officer. Just nod your head if you can hear me, making sure. Yeah, okay, great. I just wanted to let you know that we are also working really hard on the new QI withhold project. I know we've been bouncing ideas off of some of you, so really just appreciate the support on that as we redesign our incentive program, and we'll have more to come as we roll out something new in 2024. And then also with the new CHW program as well, excited that that's going to be billable for you all. And so just working on some new processes and how we're going to link our community health workers that we have on staff with those that you guys are working with, just to make sure we're getting the best care for our members, with our ultimate goal of improving that ranking with our state and having healthy team members. So with that, we just have a quick PowerPoint. I wanted to introduce you to Leslie Clements. She is our new Health Equity Director here at Humana and is really going to be working strongly on our goals of decreasing our disparities and improving the health of all of our members. So just wanted to make sure you all knew her as a resource. And she's got a PowerPoint to share. So if, am I allowed to share my screen?
Yeah, who's going to be sharing, Sarah, you or Leslie?
Yeah, I'll share it and let Leslie speak.
Just 1 second, I'll
And maybe as she pulls that up, I can let her introduce herself, and then I'll start sharing as soon as I am able.
Awesome. Thank you so much, Sarah. I appreciate the warm introduction. It's really great to meet everybody. As Sarah mentioned, I am Leslie Clements. I'm the new Health Equity Associate Director for Humana Healthy Horizons in Kentucky. And so I am starting my 3rd week on the job, and am excited to be here and be a part of this group. I'm not new to Humana though. I've been with Humana for about 17 years. And so really thrilled to be able to apply my learnings from the last 17 years in this new role. Wanted to just share with you all a very brief deck to talk through some of the work that we're doing around social determinants of health and how we're trying to address that for our members. Some of this may not be new news for all of you. I know this group probably connects regularly, so I'll zoom through this pretty quickly, but please know that I'm happy to share this deck. And there is more information in the appendix. And if there are any questions that I can't answer, perhaps Sarah can, or we can get back to you if we need to put something on the parking lot. But I'll start by just saying, you know, what we have in front of you is a high-level view into Humana's comprehensive care support team model. So when we think about our members, this is really about how do we help address the needs that they have, not only based on what we're able to identify through our fully integrated digital health and analytics tools around addressing needs, but also what is important to our members. What is it that they want and that they need based on their experiences in life? So what you see on the left-hand side of the screen are all of the folks who are really engaging specifically with our care manager to be able to address the members' needs. And over on the right-hand side are examples of some of those social determinants that we're really focused on for those members. So if you think about that care manager and the member together, they're at the center of all of this. And Sarah, if you want to skip to the next slide, what you'll see are just a very high level view of some of the value added services and expanded benefits that Humana is currently offering in this 2023 plan year. And what you're seeing are just essentially a very high level list. We've got, of course, our Humana Beginnings, which is our program for moms and babies. So if a member is in need, they can access their portable crib or their car seat. They also have access to meals after delivery, which of course we know is important for food security and nutrition. You'll see doula services. A lot of technology is listed on this slide. We've got several different apps that are helpful for members in various parts of their lives. We've got information here and supports for our members who are looking for opportunities to develop professionally. So we've got our GED Works plan out there. Also a workforce development program with childcare assistance. I'm not going to go through the whole laundry list here, but this is really just to help represent that we're recognizing the whole person. I will point out one item that's on the bottom of the list here, healthy behavior rewards through Go365. So in addition to these benefits that we make available to our members, we also reward them if they've been able to participate in healthy activities. So the next slide talks a bit about what things we will reward and what you're able to do with those rewards. So again, this is just a very high level list of some of the qualifying activities that our members can do related to their health and well-being. And if they participate in any of these activities, they earn bucks through our Go365 for Humana Healthy Horizons application. And across the bottom, you can see items that they're able to access with those bucks. I want to specifically call out the e-gift cards. We know that there are certain gift cards that we think are especially helpful for our members when we think about social determinants of health. So one example that I'll share is you can get an Uber gift card. So with many of our folks who might be encountering barriers to transportation, this is an example of one thing that we're putting in place to support that. If you check out the next slide, this is just a Humana member success story. So again, when we think about our comprehensive clinical care support model, this is an example of where Humana was able to meet a need of one of our members. So this member is just one of many who gets to take advantage of our expanded benefits. In her case, she needed financial support and she needed food security support. She had some concerns paying her bills. She and her spouse were out of work. There was a surgery on her spine. And so she was really concerned about how she would be able to pay her delinquent utility bills and put food on the table. And so that's where one of our rockstar social determinants of health coordinators came in. They reached out to the member. They conducted a social determinants needs survey, which again is one of the many inputs that we're able to use to help identify gaps for our members. So based on what they heard, they were able to provide her with education on what her value added benefits were, some of the community resources that were available to her. And as a result, she felt really confident. She felt confident that she was able to eat without concern about food insecurity that month. She was able to get her utility bills paid in full, and hopefully was able to build a stronger relationship with Humana because we were able to help support her. This last slide is just some examples of other ways that we at Humana are trying to address social determinants of health needs beyond the benefits and the value-added services and the rewards that we offer to our members. We obviously recognize that our members are part of a greater community here in the Commonwealth. And so these are just a few examples of some of the things that we've been doing to try to step up and support Kentucky, which we know in turn helps our members. I'm going to call out just one data point that I'm pretty excited about that's on the left-hand side of your screen there. Our employees are really concerned about their communities. And so we offer a lot of resources and benefits to make it easy for our employees to volunteer in their communities. And in 2022 alone, we had 53,000 community volunteer hours that were tracked by our Humana associates here in Kentucky. They gave $1.3 million of their own money to Kentucky-based nonprofits, and most of those nonprofits are supporting social determinants of health. So again, it's just another example of how we're thinking about our members and the communities that they live in. The rest of this deck, I'll forward it to the meeting leader so that you have access to it, but there are some examples in the appendix specifically about the value-added services and benefits that we're offering related to each social determinant that I glossed over on that first slide. We're running some cool pilots as it relates to transportation. Take a look at that. Please do let us know if you have any questions about any of those pilots or things that we're putting in place. And thank you so much for the time today.
Okay, thank you. Appreciate it. Thanks for that information. Any questions? Let's go on to Passport by Melina.
Good morning. I'm Yolanda Calherd with Passport by Molina Healthcare. Some of our updates are we had a recent change to our peer-to-peer review timeframe. That request has changed from the peer-to-peer from 2 business days to 5 business days. Next, we are doing a 7-question survey for our providers, requesting feedback on communication preferences, as we are looking to improve in those areas. We also have a new form for early reversal permission form. This allows providers to request us to deduct paid claims in error from future remit. We recently decommissioned our legacy portal. The last day of usage was June 30th, or for any data service prior to 1/1 of 2021. And then lastly, our member portal, we did give it a little bit of a facelift, as well as we have some new features for our members. There are some self-service options. Members have the ability to change their PCP. They can request ID cards, sign up for health reminders and services, and view their service history. That's all. Thank you.
So the peer-to-peer is going from 2 to 5 days?
That is correct.
Okay. So if somebody comes in needing an MRI, you got 5 days for a peer-to-peer to approve that instead of 2?
That is correct.
It's kind of going backwards for us. What does our other members think?
Yeah, I agree. My first reaction was that that's going the wrong direction.
I was wondering. Okay. That's kind of, let's note that.
I'll get some feedback on that and bring it back, okay?
Okay. Yeah.
Thank you.
Peer-to-peer is very important when you're out there trying to get things approved. And going to 2 to 5 days could impede care. So if you don't mind, bring us back some information on that, if you don't mind. Anything else about
Definitely.
Passport, Melina?
No, thank you.
Okay. United?
Hey, this is Greg. I'm the Chief Operating Officer for United's Kentucky Medicaid program. Appreciate the opportunity to talk today. I won't take a lot of time. I have 5 quick bullets. Number 1, we've talked about redeterminations. And I think that's on top of mind for all the MCOs. I think it's on top of mind for a lot of folks at DMS and probably our providers. So we want to ensure that members retain coverage as broadly as possible. We are doing our own outreach methods to make sure that we're connecting with members. We are texting, we're emailing, we are calling, we're sending letters. We don't have as high of a connection rate as we would want. A lot of times that is because of patient data. And so one thing that I wanted to bring to this meeting is the opportunity to share data. I know that a lot of times the touch point happens in the doctor's office more than what we might have at the MCO. And so I want to just offer broadly that if you're interested in data sharing to know when folks are scheduled to lose their coverage, please reach out to us. We are happy to share reports with you. All the providers here, if we have our signed contracts, we're able to share that data really freely. We have approval from the department to do that. And so some of our partners have already taken us up on that offer. And so I want to offer that very broadly. If anybody is interested in sharing data about redeterminations to help facilitate that continuation of coverage, we would really appreciate the extra support there. I will put my email in the chat and you are welcome to email me about that. Another item that I wanted to bring up is something that you're going to hear referred to as Project Promise. UHC has taken a look at our authorization requirements, and we have noticed certain trends that allow us to become more flexible in the way that we're doing authorizations. And so we are looking to reduce the number of codes that require authorizations in the next several months. And so you're going to see some communication about that. What we're doing is we're taking a look at all codes that are routinely approved and providers who are routinely sending approvable auths, and we are allowing them to bypass authorization requirements. So we will be publishing lists of codes that applies to. We will be working with the individual providers, but I did want to let you know that we are moving towards that to decrease some of the administration so you can focus more on patient care. Number 3 on my list, I wanted to talk a little bit about some of the needs that other MCOs have talked about, non-medical needs that we are helping to meet. I want to highlight one because we haven't seen a huge amount of utilization, and I want this group to know that it exists. We are giving diapers to any mom who has been seen at their postpartum care visit. So their 6-week visit, after that happens, they can give us a call, request diapers. I want every physician on this call to know that that's available. I want you to encourage your moms to take advantage of that. So they're getting, I think it's around $70 of diapers when they call us. So I would love to see that higher increased utilization there. So if you have moms on your plan or in your practice, please let them know that they are eligible for some diapers. Speaking a little bit more about other needs that are non-medical, I had a great experience a couple weeks ago. My team and I got to go to the Dare to Care organization in Louisville. Dare to Care supplies more than 300 food banks. They are doing some really innovative work in the community. There's a traditional food pantry model, but they're diverting from that somewhat. They are taking items that were supplied to the food pantry, they're repurposing those and creating ready to eat meals. So rather than just taking a can of corn, giving a can of corn, they're taking a can of corn, combining that with several other ingredients and making ready to eat meals for the community. And it's really helping people who have challenges in whether it's cooking, time, utilities, whatever it happens to be. This offers them a solution that a traditional food pantry or food bank solution does not offer. So we got to, I think my team and I put together, I think it was more than 700 bowls of soup that were ready to go distribute to the community. So they're doing some great work. They're also working on a dehydration process that will help our members who are experiencing homelessness in a really unique way. With a dehydrated meal, they can get any source of hot water, and that meal is rehydrated, and it becomes good nutrition for a person, even if they do not have a home or cooking utensils or things like that. So I wanted to plug this organization here. They're doing great work. They're obviously not part of United, but I think that they're doing wonderful things. I know that they're working specifically with Norton on a few initiatives, but they are open to working with more providers. So some things that they've done in the past is a prescription to food program, meaning if a member comes in with a prescription from their doctor, that they can receive a free meal. So it's nutrition, it's quality nutrition. So I wanted just to plug this organization. I feel like they're doing wonderful things in the community. We plan to partner with them in an ever increasing way because of the things that they're doing. So I wanted to put their name out for you. The last thing that I have on my list, and I'm not going to labor this point, everybody else has talked about this. We've talked about the quality initiatives. So this is going to be something that you'll see increased priority around. We're no different. So you'll see us partnering with you and several providers on this call to see what we can do to increase these quality measures, whether that is through incentive programs, value-based contracting, or other mechanisms. We are interested to see what we can do collaboratively. And that is it for United.
Appreciate it. I think you hit on a good point there, that we would like to stress from the provider standpoint as well, is we would, when we ask for DMS and the MCOs to work on, becoming more standardized with our standards of care, we were hoping that, we would develop these in a very collaborative effort. So, now that we've been proposed with these, it would be nice for us to be able to kind of maybe sit down in some kind of work group and talk about how we can work together to make this a more collaborative effort between DMS, MCOs, and providers, instead of us feeling like, it's take it or leave it. We'd like to have some input as well.
For sure. We love to collaborate with our provider partners. That's one of our primary strategic initiatives in the next 3 years, is that we want to grow our provider relationships, become more strategic with our providers and collaborative. We want to be very easy to work with, and we want to accomplish great things for people. So I think that we can do that better together.
Thanks.
Well, and I think that even as we consider some of the reward programs that have been highlighted, and I've said this in individual meetings with lots of payers, but the practicality of, that reward being meaningful to a patient when they're in the office with their provider is not relevant. So if we've now narrowed down really the measures that we're trying to improve on, engaging us in a conversation early on about ways that we can, engage patients in achieving what they need to do to improve their health towards those measures makes way more sense than saying, oh, here's our new plan. All that has to happen is your member needs to call when they leave. That's not going to be something that incentivizes something. They need it in real time when we're able to deliver the care to them.
Yeah, I think that makes a lot of sense.
Okay. Anything else with United? Okay. WellCare?
Barry, can you hear me?
I can hear you, Johnny.
All right. Thank you so much. My friend and colleague, Stuart Owen, wants to share some information about ER diversion. So, Stuart, I'll mute myself and let you share that information. Thank you so much.
Yeah, thank you, Johnny. And first of all, I want to thank Greg with United. We're a partner. We support Dare to Care as well. And you did an excellent job, Greg, of explaining all the stuff that Dare to Care does, and we totally support them. I suspect we're probably not the only two MCOs that do. I mean, they are awesome, and I think we were on site within the past month or so, doing something similar.
They're great, right?
Yes, yes, yes. So definitely appreciate you bringing that up. I was going to, if I can, share screen. I actually have one slide.
Okay, Stuart, give me just a second so I can.
Sorry. I could talk through it, but I thought, all right.
You should be able to share now.
Thank you. We have, can y'all see the screen, care management emergency room? The version?
Yes.
Okay, thank you. So we launched this this year, earlier this year. It's our care management team trying to obviously get members to ER, away from ER to primary care settings when it's not something that's emergent. And we get information. It's an initiative that we're doing this year that we launched 1/1/23. So we get information from the Kentucky Health Information Exchange, and it's real-time information about these types of, essentially it's an ER visit when it really shouldn't have been. And we also look at claims data, and we've got other internal sources to identify these visits. And what happens is we got 3 members from our care management team that will then outreach those members that show up on that report. And the whole point is, first of all, that, again, getting with primary care, do you have a PCP? Have you chosen a PCP? And so help them with that, assist them with that. Also medication adherence, we enforcing the importance of that, because that's, that can trigger an ER visit, obviously. And then also we will go with the member to the PCP, especially like it's the first time or whatever. So anything, basically the whole point is to get them to the PCP and help facilitate that and eliminate those barriers. So instead of them just using the ER all the time. So that's something that we launched this year, and I just wanted to touch on that. And I will stop sharing.
Okay, Johnny?
Yes.
Yeah, that's all we had, Barry. Thank you so much.
Oh, okay. We appreciate it. Any questions for WellCare? Okay. That's all of the reports for the MCOs. TAC members, do we have any recommendations to the MAC? We are definitely a quiet group today.
Barry, it seems relevant that we should make recommendations related to the collaboration that we discussed previously.
Okay. Definitely. We want to put it on record that we want to make a recommendation, and we will write that up as a recommendation and submit it to our primary care TAC on behalf for the MAC.
I believe that needs to be in the form of a motion and voted on.
Okay. We have a motion to make a recommendation to the MAC to request for collaboration and have more input into the establishment and the adoption of the standards of care and the value-based care models.
I'll make that motion.
Do I have a second?
And I'll second.
Okay, which one? Dennis or?
That's fine.
Okay. Okay, all in favor, say aye.
Aye.
Opposed likewise? So moved. What about the peer-to-peer? That kind of concerns me. We have one MCO that's wanting to extend it. I'd like to see, if anything, the peer-to-peer. I mean, that's one of our last resorts if something gets denied. That shouldn't be something that we put off. Would we like to make a recommendation to reconsider to keep it at 2 days?
Can I speak? This is Dr. Hall from Kentucky Passport.
Yes.
The peer-to-peer, we extended the time frame for which the provider can call in to request a peer-to-peer, not extend the time we have to respond.
Your turnaround time. Okay.
Yeah.
Thank you for clarifying that. Okay.
Yeah, that's
appreciate
a very different thing. So yes.
Okay. Yeah.
Right. Yeah, you might have misunderstood. This is Dr. Brunner from Anthem. We have a 7-day window to allow the provider to call us and request the peer-to-peer.
Okay.
We feel we want a good window, a wide window to allow that to happen.
Okay.
Yeah, same here.
That was my misunderstanding. I
Okay.
apologize.
No worries.
Glad we cleared it up. Okay. Any other recommendations for the MAC? From the TAC, Stephanie, Dennis, Michael, Dr. Hoagland? Okay. We'll make that one recommendation to the MAC. Our next meeting is September 7th at 10 a.m. So if there's no other business, I'll take a motion to adjourn.
I'll make that motion, Barry.
Okay, Dennis makes a motion.
I'll second it.
Okay, then all in favor say aye.
Aye.
Okay, so moved. Thank you all. Thanks for all the participation and all the MCOs and Medicaid. Thank you very much.
Thank you.
Everybody have a great rest of the day.
Thank you all.
Thank you.
You too.
Thanks.